Good evening. My name is Corrine McIsaac, and I am a professor of nursing at Cape Breton University in Canada. I am so honored to be talking to you today about using technology to accurately track and measure patient and economic outcomes. It's one of my passions. It has been for about 20 years, and I really believe that we need to embrace it fully and really improve patient outcomes. I am the founder. One disclosure I have is I'm the founder of Health Outcomes Worldwide, and we have developed an application that enables better care at the bedside using real-time data and artificial intelligence. The objectives I have for the presentation are to demonstrate how collecting data in a standardized methodology using technology enables more informed patient care, and to discuss the clinical and economic outcomes that can be achieved by using technology-driven wound care. I'm just going to use this as sort of an example to, there's all kinds of wonderful things going on in the world with respect to wound care. But sometimes, some places, there are a lot of factors that interfere with being able to deliver evidence-based care. And this is an example of a place in Canada that just sort of looked at one wound type, lower limb ulceration, looked at the very high cost, 521 million, multiple visits, lots of prescriptions, and lots of amputations. It also sort of described sort of the current state of the patient experience. And as we all know, with wound care, there's many specialists that do wound care. So you could have a vascular person seeing a wound, infectious disease, orthopedic surgeon, whatever is required. The other thing that we know, and it's been documented in the literature, lower limb ulceration, there is a high percentage of misdiagnosis. So the patient gets misdiagnosed, the wound gets misdiagnosed, and the patient gets on the wrong pathway. There's often limited interaction between all of these specialists, numerous tests, and the big thing in situations like this, which can be commonplace, where people are using a paper documentation system, there's lack of standardized data collection to be able to help the patient. So this is the way, the way care can be delivered, and obviously this isn't the way for everyone, but there certainly can be this types of situations. One other thing I thought before getting into the outcomes is what I wanted to look at: why, as healthcare providers, do we have an aversion to technology adoption? And some of the things I found in the literature were, no one wants to pay for new technologies. The biggest one is around risk aversion, that it's widespread, and unless, sort of we feel as a healthcare provider that it's going to be 100%, it's going to work and it's going to improve things 100%, we don't want to take the risk. Going digital, there's a lot of regulations, HIPAA and PIPEDA in Canada, and lots of extra work for healthcare providers. And this can discourage healthcare providers from technology. We fear change and that it will cause harm, and also fear an over workload. I think all of these things around technology can be overcome, and we can have a much better process for the patient, especially if you add telehealth to this. So this is just a screenshot of one of the technologies that are on the market. And as you can see by looking at it, you're not looking at a paper chart, you're looking at something that is maybe integrated into your electronic health record, but you can see the types of wounds, all on the left-hand side. You can see all of the things you can look at immediately, toe pressures, Braden scores. And the team can have a very informed vision of or version of what's going on with the patient, and be able to plan care more effectively. Many people tell us that are using technology that it also allows them sometimes to pick up very subtle details that might not be obvious, but it might be as a lower limb ulceration, it might be like a subtle change in the PWAT score or a subtle change in the SEEP or Wi-Fi score, and along with the photography, can really enhance what goes on for the patient and improve outcomes. Just to give you an idea of some of the things that we've looked at, this publication here is in Press, and it is We worked with some large groups of patients, and what we tried to do was compare healing times with wound groups. So wound groups, and you can see with technology, the healing time was much quicker than without technology. And again, what I really believe it does, it enables better care. It's the team, it's the people, it's the communication between all of the different healthcare providers that really make a difference. But technology can enable this. Another example, this was a group. They were serving a population of about 100,000 people. One of the first pre-data collections that were done with them showed very low use of compression therapy for people with venous leg ulceration. A technology was implemented, and this technology gave education sort of on the spot, took the comorbidities of the patient and the wound diagnosis, and really probed the clinician for the right questions. And in this case, this group was able to increase their use of compression therapy for venous leg ulcers by 45%. The other great thing that data does is tell us about our care. So it's the good and the bad and the ugly. Like, it's not all, it doesn't all come out perfect all the time. In this case, we worked with, this was a patient group of about around 100,000. And there seemed to be a very high use of antimicrobials. So what we were able to do is look at the data, and here you can see the blue graph is wounds that are infected, or the blue bar is wounds that are infected, and the orange graph is the wounds that weren't infected. And on the upward axis, you can see it's the number of antimicrobial dressings used. So you can see that there was a lot of overuse of antimicrobial in dressings. So again, you have to take this information, work within it, dig a little bit deeper, but at least you know these things. Patients generally were really, really happy in this particular study that we looked at with technology, and they were very happy with seeing the pictures, whether they were going for the better or for the worse, and sometimes for the worse. And being able to demonstrate that by photography using technology, it really engaged the patient more. They seem to be much more engaged in their care and committed to the plan of care. The other thing, you can look at population outcomes as well. This is a group that we worked with, and basically they wanted to know, do we have about 30% wound closure at week 4? And you can see these 4 wound types in this particular situation did, which of course indicates that they're probably on a positive trajectory for wound healing. Besides all the great clinical outcomes, there's a lot of really great economic outcomes. And this is an example just to show you on the left of the picture with the diabetic foot. That was the cost of care. It came to $89,000 over a period of 3 years with using paper, and not being able to have all of this information at your fingertips. And with using technology, a similar type patient with a completely healed wound in 11 weeks for about just around $1,100. So the cost is really clear. When we have more information, we have the tools we need to be able to make better decisions. Patients get better care. This was a little bit of a larger study, probably about 300,000 or 400,000 patients that were in this study. And what the group did is they gave the data to an independent economic expert who took a database, and basically we wanted to know, what are the economic outcomes? So the wound type is in the first column. The second column is with technology and without technology. So you can look and see that, of course, with the use of technology and having that evidence and that information at your fingertips, decisions were made, and there was better outcomes for the patient. If you looked in the improved costs, sort of in the midway there, you can see 70 to 90% improved cost. And also the last column, increased throughput or increased availability to free up a space to do more care. What this expert did is sort of put it all together, and it was from a province of Ontario where we looked at this large group of patients, and on the number of visits reduced on average per episode by 61%, the length of stay by 60%, and the cost between 60 to 80%, which equated to a potential large savings if the technology was implemented across the board. I'd love to spend about an hour talking about this and showing you more case examples, but my time is up. Thank you so much for your attention, and my references are available as well. Thank you.